good afternoon and welcome to IPC Partners Journal Club. And we've got a really exciting session today because we are partnering with the Infection Prevention Society to do a real focus on their journal, which is the Journal of Infection Prevention. And I'm co-chairing today with Jacqui Prieto, who is our Associate Editor of the Journal of Infection Prevention. And I am Jude Robison and I am the IPS President. I'll just let Jacqui introduce herself.
Thank you very much. I'm Jacqui Prieto. I'm a Professor of Nursing and Infection Prevention at University of West London, and also, as Jude said, Associate Editor for the Journal of Infection Prevention. And with my colleague Heather Loveday, who is the editor, we're delighted to be in partnership for this event. It's the first to feature the articles from the Journal of Infection Prevention, and as a Society's journal, we're really excited to be able to bring these sorts of studies to life through a discussion. And the papers that have been selected today, we think we're looking for more of this kind of paper in the journal, so hopefully it'll inspire you to get your pen and paper out and start writing. Thank you.
Thanks, Jacqui. So we've got Dr Jon Otter and Dr Phil Norville who are going to talk us through some papers. I'm just going to give them an opportunity to say hello.
Thanks, Jude. My name's Phil and my day job is that I lead the Infection Prevention Control Service at Oxford University Hospitals, and I am one half of IPC Partners with Jon. We're both really excited to be here today and see this as a really good opportunity to promote some of the wonderful work that's done with the IPS and their journal. So thanks for having us, and we're excited to talk about the two papers that we've selected today. Over to you, Jon.
Yeah, thanks, Phil. Good afternoon, everyone. I agree with that. The Journal of Infection Prevention, JIP, as I call it, is always a good one. It's always relevant to practice, and it's rare to find an article that doesn't have some relevance to what I'm doing that day. So my name's Jon. I'm Director of IPC at Guy's and Tommy's in London, and also a researcher at Imperial College London. I just want to clear something up today. My shirt is actually pink. I mean, I know it looks like it's whitey blue, but it's actually pink. I just wanted to get that in there. Jude, back to you.
Thank you very much. We'll just do a little bit of housekeeping before we get started on these wonderful topics that we've picked today. So those of you that haven't been to IPC Partners Journal Club before, it is about providing that insight on topical papers, and we've got two to share with you today, which is really exciting. And the idea is to have a really good discussion, and we want it to be as informal as possible. So we'd really like you to use the Q&A and the chat function so we can bring you into those conversations, and we can pose questions to Jon and Phil and Jacqui as well, to try and unpick some of the questions that you might have about some of the papers that are discussed today. It's also a great opportunity for CPD. It's going to exercise your critical thinking. It's going to build lots of confidence for you to think, oh, I'm going to go and do my own independent research. And I think we can already agree we've got a massive network of enthusiasts, which makes these events really, really good fun. So I do hope you enjoy and get lots out of it today. Just to let you know that this journal club is recorded and it will be made available after the event. So without further ado, I'm going to hand over to Phil, who's going to talk us through our first paper. Thank you.
Thanks very much, Jude. So the paper that I've chosen is this one here, published in JIP, published really recently in 2024, I think it was November, looking at real-time intervention to increase daily chlorhexidine bathing to reduce central line-associated bloodstream infections by Kriya et al. So I just want to start by explaining a little bit about why I chose this paper. I think something that I haven't really covered on the first slide is that any kind of quality improvement study that looks at an intervention to reduce an infection, doesn't really matter what it is always something that's of interest to me. And I've really noticed a lot of literature, a lot of evidence around chlorhexidine bathing and its role in potentially reducing various different healthcare associated infections. And this one talks about CLABSIs, so central line associated bloodstream infections. So I was firstly really interested to see about whether or not there could be evidence to show an intervention and a quality improvement tool, as this study talks about, in reducing those infections. The other point which really made me interested in this study stand out for me is just about the cost of CLABSI. Looking at the data, CLABSIs are some of the most expensive infections that we can experience within our healthcare services. So this particular estimate, which is from the paper itself, just under $50,000 US, so around about £25,000 in sterling. Talking about the case of a CLABSI is extremely high. So any data obviously that improves our patient outcomes with interventions, but also reduces the burden of cost for our organisations is really welcome. But I think the real thing which gripped me within the title of the paper was this use of real time. So I was really interested to know what the authors meant by real time, because we think about interventions within infection prevention control and within quality improvement. And one of the biggest challenges is how we implement them. So the idea of trying to implement something in real time really, really interested me. So I was really interested to dig deeper into the paper. So digging into the methods in a bit more detail, this was a quality improvement project, or a QIP, and it was done in the US in a 166-bed acute care hospital. The primary outcome that they were looking at was all around CHG bathing adherence. So what that means is when they're looking at patients who should receive CHG bathing for people with central lines, in this case, that the percentage of those patients who actually received CHG bathing, because compliance is obviously a big challenge when it comes to infection prevention control. We talk about policy into practice, so it's whether or not we can get those adherence rates that we need to try and make our better outcomes for patients. So they used various quality improvement tools, a fishbone diagram and an impact effort matrix. Some of this terminology is quite new to me, so I've used fishbone diagrams before. The idea with a fishbone diagram is identifying the possible causes for a particular problem, and they kind of all go into the skeletal structure of a fish really and lead into one central bone with your problem at the end. What was new to me was this impact effort matrix, so looking at potential impact and effort required for each particular task, so trying to relate that to CHG bathing and where some of those challenges might be. So as part of that quality improvement project, this led to them developing a development within their electronic patient record, or their EPR. So it led to the addition of a time since CHG bathing column. So what that meant, in my interpretation, is that within your EPR, you're able to look at the individual patient and look at the time since they've had their CHG bathing. And that allowed the infection prevention control team to provide real-time feedback to say if a particular patient had passed a particular threshold in terms of the time since they've had their last CHG bathing, whether or not it was 1, 2, 3, 4 times, depending on how long they were in hospital. And that allowed them to provide the real-time feedback to frontline staff. So I think that's the key thing to take away from this method section about what they identified within the quality improvement. I'm going to talk about some of the challenges they identified in the next slide, but how that real-time feedback interlinked into what they identified through the QI project. So what it allowed them to do by adding this dimension to the electronic health record was a consistent message and messaging platform that allowed them to standardize the content of the message and the method of delivery. So again, just focusing on how it allowed a standardization of that messaging to all of their frontline staff. And again, I think this is a really important point about how it bridges policy into practice, the ability for that feedback in a real usable system when it comes to frontline staff. The other thing as well, which they're really keen to point out within this paper, is that they put a sustainability plan in place. Not sustainability in the most common sense about reducing, carbon footprint or impact on the environment, but more about talking about how they could ensure that this intervention was maintained. And I think this is, again, one of the really interesting things that I'm interested about in my day job, is about how we ensure that these interventions stand the test of time. We think about putting interventions in place and they might make a difference in the first couple of months or weeks, and we see an improvement maybe in practice or in infection rates, but how do we maintain that longer term? And that sustainability plan focused around ownership and empowerment of frontline staff. So really, trying to give the power to the frontline staff to ensure that CHG bathing compliance was really high and adherence. So as part of that feedback, they were providing data on adherence to their units on a weekly basis. So there was a feedback loop as part of that to be able to ensure that rates of adherence stayed high. And again, leadership providing oversight and accountability to utilize that data was really, really key. So in terms of what they identified when they did those quality improvement tools, the key barriers that they identified was difficulty in firstly identifying patients who require CHG bathing. So the system that they put in place was trying to establish and overcome that particular barrier. They were talking about difficulties, about how it's a time-consuming process to review clinical notes. So again, having a real-time system through the EHR was allowing them to provide that real-time feedback and ensure that frontline staff could get that real-time indication of when patients required bathing. And also the challenge around documenting CHG bathing within the EHR manually was another challenge as well. So those were the barriers that they identified, and as I've kind of alluded to, they put in this metric into the EHR, about ensuring that there is a time since CHG bathing has taken place, so providing that real-time feedback. On to the results, and the first thing that struck me from this paper, that their CHG bathing adherence was also really, really high to begin with. So pre-intervention, 95% almost, which is really, really good and really, really high, and already had me asking questions about whether or not they were going to detect any significant difference. Their CLABSI rate over a rolling 12 months was 1.89. So they were looking to see whether or not the system, through what they'd identified through the quality improvement, was going to increase that adherence and also have an impact on their CLABSI rates. What they found was that when they introduced the intervention, they had a very, very small increase in their CHG bathing adherence. But what they did identify through their data was that their interventions weren't being implemented on a weekend. And this is one of the big things that I'm going to talk about in the next slide's time, is that what this study identified, that there were big differences in practice in a weekend versus a weekday. And if you think about maybe your own roles that you do on a day-to-day basis, I think we're probably all aware of the challenges that come with weekends, whether or not it's staffing, communication, they're big, big challenges. And what this study identified was there were clear differences in adherence rates between weekday and weekends. However, and this is where I started to get maybe a little bit confused in the interpretation of some of the data, and probably falls into some of the limitations that I'm going to talk about. Their pre-intervention period didn't have segmented data. So they were in the post-intervention looking at weekdays, weekends and overalls, but they didn't have that in pre-intervention data. However, when they looked at the data overall, where their CHG adherence bathing rate did have an increase. So their post-intervention weekend CHG bathing adherence and their overall adherence, actually, when they reduced that and got rid of that segmentation, they did actually see an improvement. And I'm going to just talk about that in this slide, which is tailed directly from the paper. So you can see there the differences between the pre-intervention and the post-intervention. And look, if you look at the third bar chart on the right-hand side, the overall versus the weekend, you can just see how low the difference is between the weekday and the weekend in terms of their CHG adherence. But actually, when they removed that segmentation, what they found was that they did have a overall statistically significant increase in their adherence in their pre and post intervention. So as I've kind of alluded to, they did identify those differences, and they did see an increase in CHG adherence when they removed that segmentation. They, however, in their 3-month project window, detected 0 CLABSIs. So this might have been from a result of the increased adherence to CHG bathing. And they did see an overall reduction in the 12-month rolling rate of 1.78 to 1.02. But however, they've concluded that their sample size was too small to perform any statistical analysis or analyses. So even though they had no CLABSIs, they weren't able to give statistical significance to see whether or not that was a real reduction in CLABSI. So in terms of the strengths and limitations of this paper, as I kind of alluded to, the CHG adherence was already really, really high in their pre-intervention period. They also had some challenges around the way that the data was segmented, and that there were challenges comparing weekend and weekday data. However, the quality improvement tool showed that there were big differences in that weekday versus weekend adherence overall. And that actually, when they removed the segmentation, they were overall able to show an increase in CHG adherence. However, they weren't unfortunately allowed to translate, or couldn't translate that into analysis of CLABSI data. So the question still remains as whether or not these improvements through this quality improvement tool actually led to a reduction in eclampsia rate. So just to conclude, before we go to question and answer, what does this mean for infection prevention control? Well, I think the big thing to say is that if we work collaboratively with informatic and digital teams around improvements to our electronic patient monitoring or record systems, that we can make differences and potentially reduce infection rates. I think this is a really good example of how real-time feedback can be implemented within IPC and make a difference for the better. But ultimately, one of the big things that this paper alluded to was that it requires that really important cross-functional working and multidisciplinary team engagement, not just with your infection prevention control teams, but with your frontline staff. And also, as I alluded to earlier, that leadership element is really key as well. I think it proves that collaboration works. And I think that we need to think outside of IPC and frontline. We need to think about data and informatics, which in the digital age is becoming even more important. I think it highlights as well, really importantly, the differences in practice that we might observe between a weekday and a weekend. So we're probably aware of that in our own organisations about how there are challenges around staffing potentially, and what that means for patient care. But what does that mean for our interventions as well? If we're going to put an intervention in place, does that mean that something gets done really well on a weekday, but not so well on a weekend? So we need to think about that when it comes to our interventions as well. But ultimately, I think that one of the big things is that outreach and effective reminders through this real-time feedback allowed CHG bathing adherence to improve. And it talked about the importance of consistent communication and follow-up as part of that to ensure that those adherence rates stayed really high. So I'm going to stop talking. I'm going to pass back to Jude, and I'd love to hear any questions that you might have for me. Thank you very much.
Thanks, Phil. That was a great overview. So yeah, please encourage those of you in the audience to pop your questions into the Q&A. I've got one that I'll kick us off with, Phil, just while others think about what they might want to ask you. I think I was quite impressed that the authors had actually managed to work out what intervention to put in place, because often within IPC we'll throw 2 or 3 things at something and hope that one of them works, but they'd really narrowed down exactly what they wanted to do. What did you think about that approach? Did you think that was the right thing? What did you think about the intervention?
I mean, the fact that it was a real-time one, I think, was what was really interesting to me. And I think that, you know, you make a really good point, is that we've got lots of tools at our fingertips when it comes to infection prevention control, and sometimes it can be really difficult to know where to start. And I think this really highlights why quality improvement is so beneficial within infection prevention control. So doing that analysis, you know, those fishbone diagrams, those impact effort matrices right at the beginning, allowed them to really establish where those barriers were and then put those interventions in place. So I think, you know, it was a really well thought through study in that respect. And I think, you know, thinking outside the box as well, Jude, I think thinking about something that, you know, we rely on electronic records for so much nowadays. Getting them to all talk to each other is another challenge, but having something that provides a system or a utility where the infection prevention control team can kind of directly communicate challenges with frontline staff is really effective. So I thought they got the intervention spot on. Yeah,
and I really like the fact that they then followed up that with that weekly feedback. So, you know, they were on it all the time, weren't they? Just trying to make that, you know, that adherence driven up. So yeah, I agree with you. It's a really great intervention. I think we've got to talk a little bit about the weekend versus weekday. I think, you know, anecdotally, we know that happens. And you know, when I saw the figure, I thought, you know, wow, you know, it was actually sort of higher than I thought it would be. But I guess my question to perhaps yourself, Jon and Jacqui, is actually, what can we do about this variation? You know, is there a one-stop answer? I presume there isn't, but is there anything that you've tried in your experience that's helped that and prevented some of that variation?
If I can start, I think. Sorry, Jon.
No, you go. You go.
Cheers. I think the paper actually calls out, you know, a really novel way of doing that through communicating with the frontline staff through the electronic patient record. But I definitely agree with you, and you know what they found within the paper. It's a big challenge trying to ensure that we get consistency over the weekend versus the weekday service. So I think communication really, if there's anything that we can do to kind of ensure we've got that consistency. And again, the beauty of the method that they used here is that they have a standardized message. They've got a standardized way of delivery, but they've also got a standardized messaging as well. So it doesn't matter necessarily who the member of staff is, as long as they're working and are accessing those patient records, they have an alert or they have some way of being communicated to about what needs to happen.
Yeah, brilliant. Jon, did you want to come in?
Yeah, I always thought that the rush of significant microbiology results first thing on a Monday morning was to do with delays in weekend, but actually it was obviously dodgy practice at the weekend that resulted in all those positives first thing on a Monday morning. But in seriousness, we know it's a problem. We know that standards of care around infection prevention control and all other aspects of care change at the weekend, and we can look at patient safety outcomes, and there's some data to suggest that there are several safety indicators that often go off at the weekend. So I think it's certainly a wider issue than just infection prevention and control. As to how we can solve it, I guess it's questions around: do we have people around? Do we have the right team and the right support for the organisation out of hours and at weekends? Traditionally, IPC is Monday to Friday, 9 to 5. Hospitals are not Monday to Friday, 9 to 5. I don't think we necessarily need to be 24/7, 365, but we do need to think carefully about what is our provision to support the organisation to make good decisions around IPC out of hours. And I think, as Phil's alluded to, having some kind of electronic patient record prompts and driving compliance through that is good, because that's always going to be there. Although I suspect you might find that the things that drive poor practice at the weekend and other things are also likely to drive poor practice with the use of an electronic patient record. So it's not going to be a panacea.
Yeah, absolutely. Great. And we've got a couple of questions coming in through the chat, so I'm going to divert us to a different topic around that paper, if that's okay. We've had a question around the bathing. So the question is it limited to bathing with liquid chlorhexidine, or do we include the impregnated wipe application as well? That was actually in the paper, wasn't it, Phil? Do you want to?
It was. Yeah, sure. So
come in there.
They didn't have a standardized approach. So and I guess maybe this is one of my limitations, actually, which I didn't call out in the paper, is that they were using different applications. They're also using different strengths of chlorhexidine as well. So they're using either 4% in a wash or 2% in a wipe. So it wasn't standardized in this particular approach. And obviously, we've got lots of different solutions available in the NHS, certainly when it comes to application of chlorhexidine. I think if I had to choose my own personal preference, it's going to be what aids compliance, and trying to support patients that way. If we think about the patient cohort that they looked at here, it was talking about people with central lines, so probably people who are quite vulnerable and unwell. So perhaps wipes might be a better option for those people because they're in hospital and are in bed or are immobile for a longer period of time. When I think about washes for patients, I tend to think about potentially people coming in pre-surgery and thinking about decolonization to reduce SSI. So I think it all depends on your patient cohort. I don't think there is, a one size fits all. I think that we don't want to lose some of those elements of nursing that are really important with patients in terms of maintaining dignity around cleanliness and hygiene and washing, and why solutions might be better. But I think, it all depends on, what your patient cohort is.
Yeah, thanks, Phil. That's really helpful. I think one of the things that sort of was interesting to me in the paper was when patients actually declined. And it made me think about, actually, so in that instance, would there be certain parts of the body that we would want to focus on where maybe an impregnated wipe would be more suitable, rather than somebody saying, actually, I don't want a full wash, but actually, could you, sort of look at a different way of doing that wasn't a full wash, but would still get some of that application onto the patient?
Yeah, I think the expression that they use in the paper is neck to toes in terms of the application. So I think from the evidence, we talk about not use of chlorhexidine around mucous membranes, so things like lips and some parts of the anatomy. But yeah, I think there might be potential for a hybrid approach, but I think again it depends. I guess this is one of the challenges when it comes to interventions and quality improvement, is that you don't have a standard set of patients, do you? You have variability in your patient needs and your patient population, right through to what they're in hospital for, right through to their age, mobility, etc. So I think that you need to have some ability to have flexibility.
Yeah, excellent. Yeah, thank you. Yeah, that patient-centered enough comes out there, doesn't it? Absolutely. We've had a message in the chat from Russell. Thanks, Russell. He's asking, is there a single EHR platform across all hospitals in the NHS?
It's a really simple answer, no. I think just talking about my own personal experiences is that we've got lots of different systems reporting different things, and we use some for some elements of care and some elements of reporting results. So there's variability within organisations, and maybe I'll pass over to John, but there's also variability in across the NHS, definitely.
Christine's put something in the Q&A more as a statement. She put this, going back to the chlorhexidine, this could be used with octenisan as well in terms of wipes and wash, thinking more of maybe your smaller patients such as neonates and 0 to 3, they can be exposed to multiple antibiotics, therefore greater risk of like ESBL, etc. So that's a really good point, Christine. Yeah, thank you. That's great. I think go on, Phil.
No, I was just going to say, I think that something they didn't talk about in this particular paper is whether or not there's any adverse effects when it comes to chlorhexidine, which again I've always heard anecdotal evidence for, but whether or not how much actually goes on in practice. But I think it's really good again to make sure that you've got alternatives available. So something like octenidine as an active, as a comparison, or an alternative to CHG is always good to have on hand.
Yeah, definitely. I've got another question a bit more about the methods, actually, Phil, if I can just come in whilst the chat's gone a bit quiet. Obviously, we've talked about them not being able to reach statistical significance because of the sample size. What did you think about the duration of the study? Because it seemed quite short. Do you think that might have helped?
Definitely. I think, data is king, isn't it? And the longer that your studies go on for, the more data that you can generate. So I think in their future work, they talked about prolonging the study. And I think in my talk, I talked about this idea of a sustainability plan. So it isn't just an intervention that goes on for 3 months. They want to kind of continue it. So I think maybe it's a message to the audience, is that if you're going to do research, make sure that you try and pick your intervention period really carefully. And if you don't have results within the period that you look at initially, make sure that you keep tracking those results, because just because you didn't pick something up in 3 months doesn't mean that you might not pick it up in maybe 6 or 12 months time. But yeah, definitely to try and extend it.
Great, thank you. And I think it's another observation that I'd made was around the real-time stuff. It felt like there was quite a lot of investment from the IPC team as well for that, and I couldn't work out from the paper whether it was the manual, the messaging through the system, or whether there was some sort of automated system. And I guess it would make sense if it was automated, but I couldn't work that out, actually. I don't know whether you could.
So my take on it is that the record is recording on when the last instance of bathing was, and that is directly being able to be looked at and actioned by the IPC team. So if they are seeing variation to policy, so they've passed that 8-hour window, for example, they can directly provide feedback to the frontline staff. So I mean, again, something to consider with this paper is that it did seem to require a huge amount of investment and time from the IPC team. But I guess that's the only way that you do real-time intervention.
Yeah, absolutely. Lorraine, thank you. You've put something in the chat. Lorraine's asking, are there any ways that trusts and organisations who do not have the same resource, particularly in IT, can replicate this? Great question.
Come on, John, we haven't heard from you.
Yeah, well, I think there is to an extent. I think the major benefit of doing a prompt towards best practice in an electronic patient record is that it's universal and it can be rolled out at scale. Once it's done and dusted, it's in. But on the flip side, it's very difficult to change once it's in, and it takes quite a lot of development time to create that kind of alert. And My organisation launched an electronic patient record a couple of years ago, and you may not be surprised to know everybody wants an electronic alert in the system for everything. And there's a resistance to putting in too many alerts, otherwise nobody can get anything done because it's a pop-up here for this and a pop-up here there for that. So I think it's quite hard to convince an organisation that they need an electronic alert in an EPR. And if you do take a different approach, you can be much more targeted with the areas that you're focused on. So you can spend time working, you know, a bit more old school face-to-face with areas that you know are struggling. So I think there are some advantages in taking a more traditional approach to prompting best practice. But obviously we do need to make the best use of the tools available to us, and the prompt in an EPR is always going to be a good strategy.
Yeah,
Thanks,
final point from me. I think I agree with Jon. It's about balance. So we don't want the alert going off every 30 seconds because we need to do something different with the patient. So I think if you're going to do it, it's got to be prioritized on what the right messaging is going to be. And this, you know, talked about consistency of message, but we can't have alerts for every single thing. So it's got to be some kind of balance.
Brilliant, thank you. Great stuff. Right, it's time to switch over to our next paper. So I'm going to hand over to Jacqui, who's going to introduce our next paper.
Thank you. Delighted to introduce Jon, who's going to give us the take on this paper. And before he starts talking, I think what really caught my eye with this paper was this whole issue around the uncertainty we faced at the beginning of the COVID pandemic in relation to aerosol generating procedures. And I'm sure most of us in practice were fielding questions and queries around which procedures are classed as aerosol generating. And I think certainly there was lots of concern around nebulizers. And the interesting thing from my perspective about nebulizers is that it generates a mist that's visible. So for some people in their minds, it can make something visible that would normally be invisible to them if they perceive that the mist itself has infectious agents in it. So it somehow ups the stakes in people's minds that this is an infectious risk. So I think it's quite interesting. And so I'm keen to hand over to Jon so that he can start taking us through the paper, and then we will start to ask him questions all about it once he's done. So over to you, Jon.
Okay, brilliant. Thanks, Jacqui. So yeah, I remember those discussions early on in the pandemic about nebulizers really, really well, like they were yesterday. And there was a lot of uncertainty at that time. And the problem with nebulizers is that they look awful from an infection transmission point of view. You've got this cloud of vapor surrounding the patient sometimes, depending on the type of nebulizer that you're using. So it's not so much a question of whether they produce aerosols, they do, it's whether they produce infectious aerosols. And furthermore, whether those infectious aerosols are enough for it to be considered an aerosol generating procedure in the context of transmission. I remember going on to a respiratory ward in my previous organisation very early on in the pandemic, and all the patients were on some kind of respiratory support, and it felt like a very safe environment. Interestingly, when we did the air sampling using a similar methodology to this paper, we didn't find it was particularly more heavily contaminated in the air than other areas, some of which you might not expect to be so contaminated, because a lot depends on where the patient is at in their disease in terms of how much of the virus they're shedding. And that's one of the elements that came out in the paper. So the impact of nebulization versus metered dose inhaler utilization on viral particle dispersion in patients with COVID-19. This was a really nice study. I enjoyed reading it, and I do encourage that if you haven't done so already, that you do give it a read. It's a randomized controlled trial with a crossover involved. So it's a really powerful study design, and I think the findings are helpful. So to cut a very long story short, there's been a huge amount of debate around the role of transmission of SARS-CoV-2 through the air and the relative contribution of different infectious respiratory particles. I always point back now to the latest WHO document on terminology around transmission of viruses and organisms in general through the air. I think it's quite helpful for cutting through some of the historical controversy and this sort of false dichotomy around a hard cutoff in particle size, above which or below which things always happened. And the reality is much more complicated than that. When a patient has an infectious respiratory agent, they expire a variety of particle sizes that behave in different ways depending on the circumstances. The concept of aerosol generating procedures itself is disputed by some, but it still finds a place in national and international guidance on infection prevention and control, with a higher level, if you like, of recommendations of respiratory protection when aerosol generating procedures are undertaken. At the beginning of the pandemic, there was a huge debate about whether nebulized delivery of medicine should constitute an aerosol generating procedure. I think most guidelines now don't consider nebulizers as an AGP generating procedure. But there are, I think, still a few professional society guidance out there that have it on lists of things to look out for. So as I mentioned, this is a randomized controlled trial. It was undertaken in the US. It was relatively small in terms of the number of patients that were included, 11 patients, all of whom were treated using both approaches. So using the metered dose inhalers and also a breath actuated nebulizer in this randomized crossover sequence. So that worked by one patient received either an inhaler or a nebulizer in a random allocation, and then they switched over to receiving the other treatment approach. Air and surface samples were collected at 3 time points in the study: at baseline, during treatment, and then after treatment, to allow for a comparison of the environmental burden with the various time points of the treatment series. Aerosol sampling was undertaken using both cascade impactors and also settle plates, and surfaces were sampled using swabs. So perhaps surprisingly, these were patients who were selected for being at the right point in their disease, but for being associated with transmission, contamination of the environment. But the detection of SARS-CoV-2 RNA from the patients themselves varied by the study point. And in fact, if we looked at 3 of the 11 patients that only had detectable SARS-CoV-2 RNA in 1 of the 3 study periods. So that, I think, was a factor explaining some of the rest of the results. Overall, the level of contamination of the environment, but in terms of both air and surfaces, was low. Around 4% of the samples in total had detectable SARS-CoV-2 RNA. And combined with that, in the samples that were positive, there was a low level of RNA detected in the samples themselves. I guess the headline finding is there was no significant difference in environmental contamination in the baseline versus inhaler or the baseline versus nebulizer periods. But I think that's slightly qualified by the fact that the contamination levels across the board were very low. They looked to see whether there was any association between viral shedding and some of the things you might think would be associated with viral shedding. So, for example, patient characteristics. You might look at patient viral load, maybe vaccination status, coughing, come back to that later, the length of hospital stay, and supplemental oxygen usage as proxy indicators for severity of disease. None of those factors were associated with the degree and the extent of environmental contamination. And equally, environmental factors were measured to see whether they correlated with environmental contamination. And neither temperature nor humidity nor the number of room entries, so a contextual factor, were associated with environmental shedding. This is, I think, a fairly neat visual summary of the findings. So in the left-hand panel there, you can see the room. This was done in 11 different patient rooms. So this is a schematic overview of how the rooms were set up, with the impactors in 2 points in the room, the Petri dishes for the settle plates at various points in the room, and the surfaces that were sampled. Note the ventilation grate, we'll come back to that. And then on to that schematic, in the bottom right-hand panel, you can see they've mapped the percentage of the positive sites. And you can see that in all 3 study phases, so baseline MDIs, metered dose inhaler, and the nebulizer, there was contamination at most points, at some of the points in the room. And if you look at the top right-hand panel, this bar chart shows you the number of samples that were positive at each of the sites in the room and by each of the methods. And you can see there visually how relatively low the frequency of contamination was. So strengths. It was a strong study design. It was a randomized controlled trial, including a crossover and a washout period, which helped to account for within participant variation. It included both air and air sampling was done with 2 different methods and surface sampling. So there was a pretty good overall picture of environmental contamination. I mentioned earlier patients were monitored for cough. It was quite a clever approach that I've not seen before. They had a machine in the room that was listening to what was going on and making inferences about when the patient was coughing and when they weren't. As I mentioned earlier in the results, they didn't find an association between coughing and environmental contamination. But some of the timelines of how they analysed the cough data perhaps could have been done differently to provide more insight. But it's a really nice approach and one that I think be good to be seen taken up elsewhere. They had a primary endpoint, which was the change in viral load from the baseline compared with the nebulizer, or the baseline compared with the inhaler, but they couldn't analyse that due to the low frequency and level of the SARS-CoV-2 RNA detection. They used obviously different patient rooms, and they had quite a different background air change rate, and that might have influenced level of contamination as well. 2/3 of the patients were being treated with remdesivir, and that is likely to have affected viral shedding. And importantly, no viral culture was undertaken. So we're looking at the detection of SARS-CoV-2 RNA, which could be from a live virus particle that's able to cause infection and initiate infection, could also be the remnants of a dead virus particle that is no longer viable and no longer able to cause an infection. And that method doesn't allow it. The method used doesn't allow you to tell the difference. So it's always good to ask, how could this study have been improved in hindsight or in terms of follow-up? It's tempting to say we should have added more patients because they only included 11. But actually, in this case, I don't think it would have made much difference because the level of contamination was so low, they would have had another 20 patients, recruited, another however many, what would it be, 1,000 environmental samples. And still no closer to really understanding the key differences between the risk of nebulizer versus inhaler. What does it add to our understanding of SARS-CoV-2 transmission through the air? Well, SARS-CoV-2 RNA was detected on pretty much all of the surfaces they sampled, both in terms of the air and the surfaces. There were a few that were negative in all of the study phases, but most of them were contaminated to some extent. There was even contamination of the extract vent in all of the phases of the study. That might be seen as evidence for some that SARS-CoV-2 is spreading broadly in the air, and both of these systems were a risk of airborne spread. I temper that with the fact that it takes more than just the presence of viral RNA at a distal point in the room to be an infectious risk at that point. It needs to have a certain volume of contamination in order to be able to overcome innate immune defenses and initiate infection. So I think that the quantity of virus detected is also important and plays into our risk-based decision making. Would these results hold true for all types of inhalers and nebulizers? I'm not an expert on inhalers or nebulizers, but I'm sure there are many experts who would tell us the differences between them and the risk and the differences in the risk profile, depending on the specific devices that you're using. So what does this mean for IPC? Well, I think the findings of this study suggest that neither inhalers nor nebulizers are at risk of increasing the dispersal of SARS-CoV-2 through the air compared to one another. It implies that there's no additional precautions required for nebulizers versus inhalers when we're looking after patients with SARS-CoV-2. I wish this study had been available in March 2020. It would have saved an awful lot of very difficult conversations. But I'm pleased it's available now. It's a good study. I enjoy reading it, and I hope you do too. So thanks, Jacqui. Back to you.
Thank you very much. And as we're waiting for the questions to flood in, which I'm sure they will, I wonder if you'd be kind enough to talk us through in a little bit more detail about a crossover study design. So you described it in brief, but what is it and why is it a suitable approach for this particular study?
So a study without a crossover in this context, you'd have had, let's say, 20 patients. 10 of them you'd have randomized to the nebulizer, 10 of them to the inhaler. But the problem with doing that is that those 20 patients are fundamentally different. They have different underlying characteristics in terms of their severity of disease, their underlying risk factors, their shedding, viral load, co-infection with other organisms, all kinds of things are different. So including a crossover randomized controlled trial allows us to control statistically for within participant variation. So we can take those 20 participants and give them both treatments in a randomized crossover sequence, and therefore better control for within participant variation.
Thank you. I agree. I think it added weight to the strength of this study, because actually if we'd had participants in that had a high viral load, they would have served as their own control, and therefore their data would have been included in both arms of the trial. So that's important to know. And it's probably my follow-on question would be, it was 11 patients, all of whom had a low to medium viral load. So I guess, what are the implications for patients with a higher viral load and possibilities there?
Well, I suppose the short answer to that is we don't know, because there weren't any. But what would it mean? I mean, it's so difficult to know, isn't it?
Mm.
In terms of going back to the study design, though, if there was a so-called super shedder happened to be included in your 11 patients, having a crossover in your trial is a huge advantage, because it could have skewed the whole study potentially. If you didn't have the crossover, you had one super shedder with 100% contamination at a high level, you might conclude that either nebulizers or inhalers were either better or worse in terms of dispersal. And that wasn't the case at all. It would all be down to participant selection. So it is there's also a practical advantage of including a crossover in that it potentially halves your sample size. So you need to recruit half as many patients to get to effectively the same endpoint if you're able to effectively deliver the treatment to both more than once to all patients.
Sure. It was a very neat study design, actually, wasn't it? And they were able to capture all of their data in a single day with each patient. And so their viral load on that day presumably will have been relatively unchanged compared to subsequent days. So there was a strength there. And it didn't require too long a washout period. Are you able to elaborate a little bit about the importance of a washout period as part of a crossover trial?
Yeah, so a washout period is effectively a period of time where you're not measuring your outcome, because there's a concern that there's almost a carryover of impact from the first treatment before you get to the second treatment. So in this case, you might give the nebulizer, and the effects of that nebulizer carry on in the environment into the second treatment window, and it would then influence results of the inhaler window in this context. I actually think these are probably more important in a behavioural intervention, because if we were doing a behavioural intervention on a ward scale and doing a crossover, you might expect there to be a kind of carryover of that intervention even when you stop actively pushing it. So you tend to find washout periods in a kind of behavioural randomised controlled trial will be considerably longer than was required in this one.
Thank you. That's helpful. Now I have some questions coming in. So Samantha asks about the air changes in the room. Were the air changes within the patient rooms consistent?
No, they weren't. It's a good question. So they had two types of room in this study. One had 4 air changes, one had 12. So there was a fairly significant difference in which of the rooms the participants were in. When they did the analysis of contamination, they didn't find that the number of air changes affected the viral shedding into the environment.
I think the majority of patients, it was 9 of the 11, were in the 4 changes in an hour.
Was it 9 of the 11? I knew it was quite a high proportion of one or the other, but I couldn't remember which one.
Only 2, I think, had the higher rate of air change, but it's an important distinction to make. Sharon is keen to know, were patients vaccinated or a cross-section?
Cross-section. So there was a difference in vaccination status. I can't remember the exact proportion now. I think I'm going to guess 2/3 vaccinated, something like that.
I think, yeah, I'm just checking. I think the majority in this study were unvaccinated, actually, weren't they?
Oh, was it? Okay.
Yeah.
But there was a difference in vaccination status, which again, when they looked at the data at the back end of the study, they didn't identify an association between vaccination status and the extent of shedding.
Indeed. Gareth is asking, found a study highlighted the importance for ventilation and bed spacing in patient cohort areas, along with consistent cleaning of patient bed spaces. So can you tell us a bit about the importance of bed spacing and ventilation in this context?
Yeah, so these studies were undertaken in single room settings. So I think the first thing to note is that we can't really comment directly on the findings from this study and how they might impact multi-occupancy based settings. However, that being said, they did find contamination of the ventilation grills at the extract point. I can see two schools of thought on this. I remember Martin Kiernan talking quite a lot about contamination of sinks and drains with antibiotic-resistant bacteria, and saying, well, actually, if you're going to find antibiotic-resistant bacteria anywhere in your room, you'd want it to be down the sink drain because it's probably coming from people washing their hands. And it's a little bit like with the extract vent. You know, if you're going to find SARS-CoV-2 in the air in a patient room, I'd like it on the extract vent and not the supply, if you know what I mean.
Yeah.
Because that means the extract system is doing what it should and taking the contamination out of the room. Yeah, as for the kind of implications of this for a multi-occupancy space setting, I think it is quite difficult to interpret what the detection of SARS-CoV-2 RNA, particularly at a low level, means. I'm tending towards meaning this is not significant levels of contamination because we know enough about molecular diagnostics to know that the levels of contamination they found in this study are unlikely to be culturable and therefore quite, I think, unlikely to be a risk for cross-transmission.
Which is quite a helpful thing to pass on to colleagues on the front line who have worries about all of this, but we'll come back to that.
Yeah.
The question in from Gail, who'd like to know were all patients using the same manufacturer nebulizer and inhaler?
I think they were. I'm pretty sure they were.
That was my reading of the paper as well, actually.
Yeah,
I think,
yeah,
they were. And Martha, can we conclude that the results can be transferred to all other respiratory viruses?
No, I don't think we can, because obviously every respiratory virus has its own foibles in the way that it behaves. But I do think there's broad comparability between something like SARS and probably influenza and other viruses in a similar sort of category in the way that they spread. There's perhaps a distinction to be drawn with other viruses like measles, which do seem to have a different route of transmission. Phil, if you want to come in on that.
Well, I was going to come back and ask you another question about this idea of, you know, aerosolization of viral particles and survival on surfaces, and whether or not do these organisms survive in the environment long enough for surface transmission to be a thing. And I think that it does, but it all depends on, you know, how long, doesn't it, and what the patient cohort is. But I think if one thing the COVID pandemic has taught us is all around how that airborne transmission route is really, really important. And if surfaces are contaminated as part of that, then obviously it's something that we need to consider when it comes to decontaminating the environment. But I think that there's now a bigger focus, isn't there, around ventilation and ensuring that we can kind of reduce the potential mechanism of transmission through the air. But I don't know if you have an opinion, John, about that idea of, you know, how much of a factor is surface contamination when you've got viral aerosols in the air and sitting on surfaces?
Yeah, good question, and not completely resolved. But I think on the basis that these findings, the frequency and low frequency and low level of contamination they found on the surfaces is not ringing alarm bells for me around really important contact transmission route. It's not to say we shouldn't have a clean environment and focus on cleaning and disinfection at all times, because we never know what other organisms are around. But for this organism and in this setting, contact transmission didn't look like a biggie to me.
Thank you. We have a question in from Russell, who's mentioning that there is a type of engineering control for administering nebulized medication called a filter mask. Importantly, it appears to be effective to contain the medication being provided to reach the patient's respiratory tract, as well as protect the healthcare personnel providing the same. Unfortunately, the availability of the filter masks seems to be limited at present. Do you have any experience with use of this type of mask? And I can ask both of you that, I think.
Yeah, I have had a look at the various options to try and sort of contain infectious aerosol at the point of delivery of a medicine. So we've seen the various kind of hoods that go over the patient delivery area to sort of suck out aerosol locally, various different putting filters in the system at various different points along the delivery line. I think on the basis of this study, again, I'm not sure that's going to be so necessary for this sort of treatment. And perhaps a filter mask might be more relevant for other forms of respiratory support that do generate infectious aerosols.
I thought one of the interesting things, we said we'd talk about cough, didn't we? You mentioned that earlier. And in the kind of the background part of this paper, the authors mentioned how a metered dose inhaler can actually trigger cough and therefore bring in that element of risk when a person's in a room supervising an inhalation process. And so, and this had a very sophisticated approach to measuring cough frequency and reporting it. But when I looked for evidence about the timeliness of, do we know coughs were being triggered more frequently for metered dose inhalation compared to nebulizer, it didn't report in that way, so we weren't really able to figure that one out. Any thoughts around that?
Yes, it's a shame, isn't it? Because it would have been nice to see that and provide some evidence either way on this idea of inhalers prompt more coughing than do nebulizers, which is something that I've heard a lot. And I haven't looked specifically for evidence for it, but this would have been an opportunity to provide that kind of evidence, because it was a continuous monitoring setup they had for the coughs. And a shame in a way that it didn't associate itself with shedding. That would have been a nice outcome, but it wasn't to be.
No, and it almost, if you're trying to provide messages to staff about managing risk, it's thinking they might have a lot of anxiety and worry about nebulized medication, but actually if there's more risk to them from metered dose inhalation because the person's going to be coughing more, it's a sort of a presenting all that we know rather than fixating on the one thing that healthcare professional is particularly bothered about. So I think we're coming to the end of our time, but one thing I wanted to ask you, just as in summary with this paper, is in the light of what we know from this paper, what would you say to a member of staff now who's concerned about the risk of acquiring infection from a patient with COVID during administration of nebulized treatment?
Yeah, that's a very good way to end it, really, isn't it, in terms of that so what kind of question. I think I'd probably say what I said in March 2020, but just with a lot more confidence now, because in March 2020, I think quite quickly we came to the view that aerosols were produced by nebulizers, but they were unlikely to be infectious. And there were some statements from the government to support that. But now we have some really solid evidence that really doesn't look like the case. So I think we can be relaxed around nebulizers and focus our attention on other procedures that might generate and situations that might generate other more infectious aerosols.
Thank you. Getting some applause here. That was a superb presentation, and thank you for summarising the paper so beautifully and fielding the discussion. Really enjoyed that. I'm going to pass back to Jude.
Brilliant. Thank you so much. I've really enjoyed this session. It's been so thought-provoking, and I just want to say massive thank you to IPC Partners for partnering with IPS to feature JIP today. It's been fabulous. Thank you.
Thank you from me as well.
Thanks very much. We'll just finish with what we've got planned next. So for those of you new to IPC Partners Journal Club, we try to run this section or this journal club every 2 weeks. We're taking a little bit of a break for half term over Easter, but our next one is on the 30th of April, where I'll be talking about challenges and future perspectives in something I'm very passionate about, environmental decontamination. And then we have a sponsored journal club on the 7th of May in conjunction with ARCA, talking about gloves, when to use them and how to choose between them. But yeah, Jude, Jacqui, it's been an absolute pleasure. And I think, speak for Jon as well, we've really enjoyed it, and thanks to the audience as well for the interaction. Great to see so many of you online, and hopefully see you at the next one.